And good evening, all. Welcome back to my advances to European Fertility Society, and welcome to our webinar tonight. It's great to be back with our special guest, which you can see her right here. Dr. Laura Garcia is with us. So, hello, Dr. Garcia. It's great to have you back. It's been a while, as we already talked about, but I'm glad you were able to find some time and present our topic tonight. How are you feeling tonight?
I'm good. Thank you very much. I'm very glad to have this chat about implantation failure and give new hopes.
Exactly. This is why we are also here. So remember, we will start with the presentation on our topic about implantation failures. And if you have some questions ready, you can put those in the chat section right now, or you can leave them for later. As you know, we will have the Q&A session right after the presentation. So don't hesitate. This is your time, and I'm sure you will have many, many questions. Before we start, let me just add that we European Fertility Society, we are proudly supported by Phenomatch. And if you don't know, Phenomatch is a face matching tool to help you find an egg donor or sperm donor. And actually, I know that Clinica Tambre is also using this technology. So we are very happy that we are able to also be supported by such an excellent company. And of course, as you know, we are still looking for volunteers. So if you would like to help us, get in touch with me. There are some few tasks that we can share with you, and I'll be happy to give you some more details. So please just email me, Caroline at europeanfertilitysociety.com, and that way, of course, I will be happy to give you some more information. And if you would like to donate, please go to myivfenses.com website. There is an option for you to do it. This is just so we can support all our community, everyone that is struggling with infertility. You know all of it, so it would be great if you could go ahead and help us out as well, of course. And right now, I think we can go ahead with the presentation. Tonight's topic, as you know, is what is the best way to assess implantation failures. And with us, we have Dr. Garcia. She's the medical director of Clinica Tambre. Again, it's great to have you here. And I believe we can start with our presentation. Yes, Dr. Garcia? Your microphone is off, so please turn it on, okay? Yeah.
Thank you very much, Caroline.
Thank you indeed.
And we will start with our presentation today. The topic is what is the best way to assess implantation failures in IVF? So for sure, we have lots of patients having this problem. So we will review slide to slide different aspects. We will talk about definition. Then we will introduce possible clotting alterations that could lead to implantation failure, also immunological alterations. The main problem, which is always embryo factor, that could be caused by male factor, always very important to study uterine factor, and then we will do other recommendations. So let's talk about definition. What is embryo implantation procedure? So it's the procedure by which the embryo on the blastocyst stage joins the maternal endometrium to carry on its intrauterine development. It has different steps. It has first the hatching, apposition, adhesion, and invasion. Of course, when there is an implantation failure, we don't know at what of this step the embryo is not able to succeed, but we know that it's not working. So the implantation success depends on mainly gametes quality, so eggs and sperm, that will give us the embryo quality. The, of course, technique and the correct moment to do the embryo transfer. So, of course, a very good embryo, if we don't transfer in the correct phase of the luteal phase of the endometrium and with a very good technique, it's not going to implant. Also, it needs the proper dialogue between the embryo and the endometrium, and that's the reason why possible problems in coagulation or immunological system can lead to failure, and a suitable luteal phase support. So there are different definitions for implantation failure, and we just select the one from our society, from the Fertility Society, which says the implantation failure is classically defined as a failure to achieve a pregnancy in women younger than 40 years old after having transferred at least 4 good quality embryos in cell stage, which means day 2 or day 3, in both fresh and frozen embryo transfer. Of course, reproductive treatments are really having more and more techniques. So it's not only for women younger than 40 years, but it's considered when the eggs are for less than 40 years or even PGTA tested. And when considering blastocysts, there are some authors that talk about 3 blastocysts and not really necessary 4. So what is not an implantation failure? So if we work with patients without IVF more than 40 years old, it's not an implantation failure, because the main reason why this woman is not successful, it's because of the X abnormalities in chromosomes. Also, if no matter young or elder woman, low ovarian response or low ovarian reserve, that will lead to a poor number of eggs retrieved in the egg puncheon, so a low probability to select good embryos. Of course, other reasons that are not implantation failure is, for instance, medical conditions such as endometriosis or hydrosalpinx, low quality embryo transfer, uterine cavity alterations such as polyps or fibroids that could lead the cause of the failure, and also an inappropriate endometrium development such as the refractory endometrium, which is very thin. Let's talk one of the first part of the implantation failure, which is clotting alterations in our hematological system. It could be some hereditary thrombophilia, such as factor V Leiden mutation, factor II prothrombin mutation, MTHFR, which is involving in the folic acid metabolism, factor 12, and many others that are also genetic. Also deficiency in protein C and protein S, antithrombin 3 deficiency. So this could lead to the need to use aspirin and or heparin. There are other problems that could affect clotting alterations, such as antiphospholipid syndrome, which is women creating antibodies in the blood that could, such as anti-cardiolipin, anti-beta-2 glycoprotein, lupic antibody, that could also affect the embryo implantation. The second problem that could be involving implantation failure is the immunological system. So, for instance, we have many patients on the reproductive treatments that have antithyroid antibodies. Perhaps we know this in a first consultation and we don't consider necessary to treat with prednisone. But if we have antithyroid antibodies with high levels, we're also using levothyroxine in order to try to have a very good TSH level, but still the embryo is not implanting, we will strongly recommend to use prednisone. As I said before, antiphospholipid syndrome, which is between the immunological and the coagulation system, involving antinuclear antibodies, anticardiolipin, anti-beta-2 glycoprotein, and the lupus anticoagulant, could also be associated to failures or miscarriages. And apart from the reproductive problems, could also lead to thrombosis. So then, in that context, we will always use aspirin and heparin. There is also a controversy in the natural killer cells, but again, if 3 blastocysts have been transferred, good morphology, with good endometrium, with everything control, then we ask that lady to have blood testing for natural killer cells. Natural killer cells could also be checked in the endometrium. So it depends on each clinic if they test in the blood or in the endometrium. But anyway, if we have an expansion of the natural killer cells, which are cells that we always have to prevent from virus and from other problems, infections, but in the context of reproductive outcome could lead to failures, of course, we will recommend have immunological consultation in our unit with our experts, and they will recommend if we will use corticoids such as prednisone, or if we will use intralipid infusions or immunoglobulins infusions to try to reduce the natural key cells expansion. Also, apart from this possible high percentage of natural killer cells, we have some women having expression in the receptor of their lymphocytes called KIR-AA. This KIR-AA is linked to more problems with miscarriages, complications during pregnancy, and also eventual failures. So, in the event of not being able to find any other reason why the failure is happening, we will always select, if possible, in the context of donation, donors having C2C2, which is the best combination, C1C1, which is the best combination for KIR-AA. But if both are eggs and own sperm and we cannot change, we will also treat with immune medication in order to make that response between KIR and HLA less aggressive and have more probability for the pregnancy to continue developing. What about other problems involving immunological system? So I don't know if you've ever heard, but there is many patients having failures that we need to remove gluten from their diet because, again, we've never found any other reason because of the failure. And we see that that person has a genetic having more risk of celiac disease, or we have the diagnostic of celiac disease. So then, of course, we will recommend at least 1 month before transfer with a gluten-free diet. And of course, during all pregnancy. What about embryo factor? So, of course, it's very important to classify the embryo as good, intermediate, or bad quality, depending on the cell number, the percentage of fragmentation in their cells, the nucleation, alterations in pronuclears or backwells, and also in what moment they are having divisions. So we know the development from fertilized eggs. First, 24 hours later, needs to have 2 cell stage. Then on day 3, the embryo needs to be around 4 or 8 cells on day 3. On day 4, that cells are starting compactation in a stage called morula. And on day 5 or eventually day 6, they need to go to the blastocyst. With regards to the blastocyst, we have more possibility to classify as good, intermediate, or low quality because it's a more expanded structure of embryos, and we have the expansion, the trophoectoderm, and the inner cell mass to classify. So good quality embryos, of course, are more leading with, the age. And also we need to remember that with more advanced age, not only the external quality, but also the internal chromosomes have more risk to be abnormal. And that's the reason why when we have more than 38, 40 years, women with failures of IVF, we always recommend to test with PGTA. What about male factor? We are always talking about the age of the eggs, the age of the women, the quality of the eggs, the chromosomes in the embryos that could be abnormal due to the age of the patient. But of course, male factor exists. So we always recommend to do a basic semen analysis to check concentration, volume, mobility, but also to check fragmentation, and not a general fragmentation, but to really investigate if it is the single or the double fragmentation which is high, and what eventually we can do for that patient in terms of pre-treatment and technique in the lab to maximize the outcome for the IVF. Also, in very specific cases, we will always recommend fish or chromosperm to really understand if there is a genetic problem in that patient. So again, basic semen analysis, we will need to confirm if volume is in the normality of between 1.5 and 3 milliliters, if concentration is minimum 15 millions milliliter, motility progressive at least 32%, and morphology at least 4% of normal sperm. So even in normal sperm parameters, we really need to check the comet fertility fragmentation to make sure if that's another possible argument for the failure. So we will check single and double DNA fragmentation tests. And what is the fragmentation? It is in the head of the spermatozoa. We will check the brain of DNA if has damage, if has interruptions, or if by contrast it's correctly integrated. So for ICSI, we need, if the high rate of single-stranded DNA fragmentation is high, we will have a low fertilization rate. And if the problem is in the double-stranded DNA fragmentation, it's a possible problems in the chromosomes of the embryo. Both of them will lead to low implantation failure. What other problems we could have in the sperm and what are the possible testing? So genetic testing such as chromosperm or fish that with different strategies will consider if the possible problem of the failure is because of genetic abnormality in the embryos and if the reason is the sperm. In that context, then, we should consider a sperm donation. What about uterine cavity? So we always recommend for people having multiple rounds of IVF, multiple implantations, to make sure with a 3D scan if there is any problem that we have not been able to study with 2D scan, such as very tiny polyps or fibroids. That could be fibroids in the cavity, so the submucosal fibroids, and also some other problems that could be only regarded with hysteroscopy, such as Asherman syndrome, which is a problem after different surgeries in the endometrium that leads to very sticky endometrium that makes the endometrium not to be thick. Other situations that we need to exclude always is also in 3D or 2D scan, hydrosalpinx. So in case we have this, we really need to do salpingectomy before other transfer. And also we need to exclude with 3D scan or with MRI if there is a problem with the cavity, with the shape. Perhaps there is a T-shaped uterus, perhaps there is a septum. So all this we need to integrate with our possible hysteroscopic surgeon to decide if we need to have any approach and improve the cavity. Also, if the lining when we're going to transfer, it's not competent, so it means that we don't have a good thickness, at least 6.5 millimeters, so the ideal it's minimum set, but it's not good. We will change our strategy. We will not try to transfer on that month and try to have a much better endometrium, such as using aspirin, such as using Viagra or vitamin E or many other medication that could increase the size of the lining. So, in the event of implantation failures, we always recommend 100% to everybody, no matter if it's egg donation, if it's IVF, to study the window of implantation, to study the endometrial receptivity. And also before a possible next transfer, to make sure if the embryos it's euploid. So to make sure if the embryos are PGTA tested or not, because these are the main reasons why embryos are not implanting. What are these possible problems? Tests. So it could be in the endometrial receptivity, it could be the era or time. So different brands are always studying this. And also for the infections or microbiome, we can test others such as Emma, Alice, or Meta in other brand names. That will be biopsies that will let us know if there is a problem with infections or microbiome abnormalities. So the window of implantation is known as the period of time when the endometrium has the best conditions for the embryo implantation, and so the receptivity of the endometrium. This period is short and it depends on the effect of the estrogens and the progesterone in the uterine lining and varies between women, of course. It is reported that 30% of women have a not normal window of implantation, and we should investigate before further transfers. So 30% of patients will have abnormalities in this test, will have different gene expressions, and we will personalize the embryo transfer in another moment and not the proctal. So the diagnosis is done by a biopsy that will let us know in the endometrium how is everything. And in the event of infections or problems in the microbiome, we will do a pre-treatment the month before another transfer. The PGT is a testing that allows to select only chromosomally healthy embryos, and it has increased chances of having a healthy baby by reducing the risk of miscarriage, and there is an increased probability of pregnancy per transfer because there is the single transfer recommended when euploid transfers. It reduces duration of treatment and number of cycles needed. So the indications are always advanced maternal age if considering own IVF, of course, karyotype alterations, and also the screen of monogenic genetic diseases if necessary in the PGTM. So as a resume, PGT is the general protocol, but in the event of failures, we will focus in the PGTA, which is the detection of loss or gain of genomic regions studying the 23 couples of chromosomes. So thank you very much for your attention, and I hope you found interesting this chat today, and I will be happy to answer all your questions.
Brilliant, as always. Thank you so much for your thorough presentation with explaining everything, of course, on our topic. And while you were presenting, there were lots of questions already here. So let's have a look at them, and let's start with our Q&A session. Okay, Dr. Laura, are you ready?
Absolutely, I'm ready.
Okay, perfect. Glad to hear that. And let's have a look. Anna has the first question for you. I booked an appointment with a reproductive immunologist, but I'm a bit worried about what might be prescribed to me, prednisone, baby aspirin, interlipids, IVIG, etc. How harmful are those? I heard some decrease your immune system. Does it mean there is a greater risk I will get diseases, for example, cancer?
So there is not any evidence with these treatments and cancer. So of course, all this medication could have problems, especially as the lady is saying, it's a reduction in the immune system. So that's the reason why we always recommend to, for instance, in the event of the pandemic of COVID, so be careful and have more, attention. By contrast, if the problem is the immune system, I would strongly recommend to take this medication because I have had multiple patients having failures, and only when they have had a very good immunological approach, we have been successful.
All right, I believe it is clear. Anna, thank you so much for your question. And let me have a look at the next question, okay? Quite a longer one, so let's see. I'm 36, doing IVF to exclude a genetic condition. I've had 2 medicated frozen embryo transfer. First ended in a chemical, and through second didn't implant. Both embryos were day 6 euploid and grade 6 BB. Both times my lining was 8.1 millimeters trilaminar, and I was on blood thinning injections. I've been told I have very mild adenomyosis, but my clinic says that it's so mild it shouldn't have an impact. My partner and I have been able to get pregnant and stay pregnant naturally before, but when we started IVF, he was found to have high sperm DNA fragmentation. We have used the fertile chip to help with this. I've had 2 saline sonograms, microbiome and infection testing, TSH level blood tests, all of which have come back completely normal. Can you advise what we should try with our next euploid embryo transfer? Should I have the ERA test? Should I consider natural modified frozen embryo transfer instead of medicated? Would you recommend any immune testing if we've been able to get any and stay pregnant naturally before?
So thank you very much, Marianne. I'm very sorry for these failures you have, but I'm pretty sure if you do things correctly, you will be successful. So first of all, it's not a rare condition that we have had like previous pregnancy, but then we don't know the reason why this is not working. In your case, adenomyosis, even being mild, it could be a problem. So we have lots of clinics that they are not considering the adenomyosis protocol, but we always recommend in the event of failures and in the event of adenomyosis diagnostic to do the 3 months blockage of, inducing menopause to try to reduce the activity of adenomyosis. Also, I will strongly recommend the receptivity, the ERA test, just in case you are doing now the artificial cycle instead of natural cycle and your window of implantation it's not correct, but 100% testing immune system. Sometimes patients, they don't have the same blood system when they were pregnant than 5 years later. So it could be that you're starting having some antibodies in your body that before you did not have. And we should perhaps treat with prednisone or any others and not only injections for your blood thinning.
All right. Thank you so much for your question. Hope that helped as well. Thank you so much, Dr. Laura, as well for that answer. Okay, Olga has next question. I'm 34, AMH5, PCOS, and common corpus luteum cysts. My husband is 38, low motility, normal count, 25 natural retrievals, 8 transfers, 1 pregnancy, had to terminate at 13 weeks for anatomical malformations, 1 biochemical, 6 failed transfers, clear hysteroscopy, endocrinologist check, trilaminar more than 10 millimeters lining check, done RI testing, been recommended naltrexone, baby, aspirin, and prednisone. Any other thoughts?
Yeah, so we don't know why, Olga, sometimes very young women with PCOS, they have bad, egg quality or poor ovarian quality, and then we are not successful. So my recommendation in your case, it's first before to move on, even that we had this 13 weeks termination, to do IVF with PGTA and make sure that the embryo before transfer it's chromosomally okay. I think it's the main aspect in your case, probably this. Of course, I will, suggest to confirm about, other testing. But if you've been tested and you already have the indication of aspirin and prednisone, I believe it's more to do with embryos in your case.
All right, Olga, let us know if that was helpful for you. I believe so. Okay, thank you. And Libby has another question. So I'm 38, recently suffered a chemical in July 2022 after the transfer of grade AA blastocyst embryo from a donor egg. It was our first ever positive pregnancy. Since then, my TSH has dropped to less than 0.01, and I have recently been diagnosed with Graves' disease. Before the pregnancy, my thyroid has never been an issue. I had my NK cells tested through a blood test, and it came back that I had a high level of NK cells and high cytotoxicity. We want to transfer another embryo SAP, but are unsure of what further tests are needed and what treatments I may need. I'm waiting on my oncologist to suggest what anti-thyroid medication I may need. Can you advise?
Thank you very much, Levin. So yes, unfortunately, thyroid is a big problem in reproductive treatment sometimes. Sometimes we checked and then it's only like 2 months later that the level is not perfect and it starts like increasing a lot or reducing a lot, and also in your case with, antibodies, whatever. So before transferring another, I will recommend the receptivity testing if you've never been with an ongoing pregnancy, because biochemical pregnancy could also be a problem in the endometrium. So I will exclude problems with, the test of receptivity and infections. And also before another transfer, have the advice of an immune expert to see how we can reduce the natural killer cells by using prednisones or intralipids.
Thank you, Libby, for your question. Jane, sorry about that. Of course, I missed your question, but here it is. So don't worry, I see them all now. So this is the next question. I have recurrent implantation failure, multiple euploid transfer failures, never had a positive pregnancy. I have a complete HLA GQA1 match with my partner. I have peripheral NK cells of 15%. NK uterine biopsies are normal. I didn't respond to 2 donor pulled lids, so I'm having another 2 sessions. I'm heterozygous for PAI1 and MTHFR. I have Hashimoto with thyroglobulin antibodies. I was found to be very receptive on ERA twice, but we are now ignoring this and we'll do normal transfer timing, as the lab said it could be due to me having undiagnosed hypothyroidism, now under control, and fibroids. 2 small submucosal fibers that I was told are so small they wouldn't have made a difference, 10 millimeters and 20. I have just had them removed with abdominal myomectomy. There is a plan for me to take prednisolone, Clexane, and have intralipids in my medicated frozen embryo transfer cycle. Is there any hope? For me, our embryos are high graded and euploid.
For sure, Jane, you have, of course, still possibilities. So if you had some mucosal fibroids and you were transferring, that was possible the reason why it was not successful. So we have many patients that they have lost many embryos in the event of fibroids or polyps. So that's the first thing. I'm happy to know that you have removed that fibroid. I would not recommend excluding and ignoring the error test, because it's one of the possibilities why you are not implanting. So before transferring again, even you're going with another strategy of embryo transfer, I will definitely, check the receptivity. And of course, if you have the Hashimoto and all this, you will always need to use the prednisone and treatments in parallel to maximize implantation. But probably your failures were due to the fibroids.
Okay, thank you. And actually, Jane has a follow-up, so let me go to this one right away. Sorry, just need a second. Yeah, here it is. What is the issue with MTHFR? I am taking 5 milligrams methylfolate. Does this resolve this issue?
Yeah, it depends on if it's homozygous or heterozygous and also how the level of homocysteine is. So normally with 5 milligrams of methylfolate, it's okay. But sometimes we also add heparin in order to try to maximize the implantation rate and try to reduce the homocysteine level.
All right. Thank you so much. And there's also thank you from Jane for you. And once again for the next question as well. All right. Brilliant. Thank you. And let me just go to the next question. I think I missed one more from Anna. Sorry, just give me a second because they're very long. And oh yeah, here it is. So how long before frozen embryo transfer is it important to eat super healthy?
I mean, of course, it's important to eat healthy for no matter, what system in our body. But of course, I would say definitely it's not the main reason if we're not eating lots of vegetables and fruits, the reason why of this is a failure. But of course, I always say to my patients, listen, we need to try to maximize all, strategies for implantation, which is, avoiding tobacco, cigarettes, trying to reduce this maximum alcohol, trying to exercise, and also to control our body mass index, and not only the body mass index, but also to try to maximize the antioxidants of fruits and vegetables. But this is not the main reason why embryo is not implanting.
Thank you for reassurance here as well, of course. And let's have a look. Katrina has another question. I heard about treatments with plasma for treating refractory endometrium. Is this true? And do you do it at Tambre?
So yes, for refractory endometrium, it's a big problem, and we never know exactly what is better. So there is not any, statistically, evidence that really says what we need to do. But yes, it's a strategy to use plasma in order to improve the functional and also to try to increase the thickness of the endometrium. And sometimes we also do this treatment in our clinic.
Okay, thank you. And there is a follow-up from the previous patient, Libby. If you can have a look. Okay, let me go straight to this one. Just a follow-up. You mentioned consulting an immune expert. Could I consult your immunologist expert, Tambre, even though I am having treatment at a different clinic?
So normally our experts are only focusing with our patients because we have a very, important unit of immunology because we have a lot of complex cases in our clinic. So it's not only the possibility to check with our immune, but we also, sometimes receive embryos from other clinics, patients that they have tried multiple transfers in other clinics, but they still have embryos. So of course we could help you, but in the event of transporting embryos to Tambre.
That makes sense, of course. Thank you, Libby, for the question. Thanks for your answer. Okay, and Anna, I would like to know, would you recommend a hysteroscopy after four failures with tested embryos, but over 40 years, even though Alice showed was normal and no suspicion of anything except a 20 millimeters
Yeah, of
thyroid?
course, if not only Alice, but also Era was normal. So if we exclude the endometrium, then absolutely yes, I will do the 3D scan or hysteroscopy and also coagulation and immunological testing to exclude problems in the blood.
All right. Thank you so much indeed for that. Okay. Kelly has another question. I'm heading into my sixth frozen embryo transfer using embryos created with donor eggs and donor sperm. All my embryos were PGTA tested and are euploid. After my second failed transfer, I went to see, sorry, not sure here. And I have had
Recurrent implantation.
Yeah, thank you. And have had 3 transfers on his immune protocol. Of these, I had one chemical and the others failed. I get the I got the Receptiva test and it was positive BCL6. I did 2 months of Lupron depot and still had another failed transfer. Any suggestion for my final transfer?
Yeah, I'm very sorry, Kelly. I understand this is really frustrating. So sorry for that. So in this context, I would strongly recommend doing 3D ultrasound with an expert to exclude adenomyosis or problems in the cavity. For sure, doing the receptivity and microbiome testing, and probably I will have a second opinion with other immunological experts, because I have had some patients that they were, asked to have immunological treatments where they were very, very suppressed with very high dosage of prednisone, for instance, and that was the reason why they were not able to implant.
And thank you indeed once more for that. Okay, maybe let's have a look at this question from Belinda. Next one. I read on a lot of IVF groups on Facebook, mostly ones that are wrote like USA patients are prescribed antibiotics to take from transfer. Any thoughts on that?
So we don't recommend antibiotics for everybody. So the protocol in our clinic is before egg collection in order to reduce the risk of problems of infections in the ovaries, but not before transfer. So it could be an approach to give probiotics for everybody before the transfer, as long as many patients have low lactobacillus rate, but not antibiotics. I would never recommend, generally speaking, antibiotics.
Okay, thank you for the clarification in your question, of course, as well, Belinda. All right, Marianne has one more question. Do I need to have the ERA test if I'm planning on having a modified natural or medically modified natural frozen embryo transfer, or is it the ERA only done, or is the ERA only done if having a medicated frozen embryo
No,
transfer?
of course, Marianne, we always recommend, no matter if it is natural or with medication, we always recommend, in the event of failures, if implantation failure, to test with ERA tests. Always reproducing the same as what we will do in the cycle of the transfer, of the real transfer.
Okay. Thank you. And one more, actually, from Marianne. Do you see patients who've had previous failures with euploid embryos and have improved success rates after doing the ERA and adjusting the progesterone timing?
Yeah, of course, Marianne. So I'll just want to say to everybody that not all euploid embryos are capable to implant. Of course, when an euploid embryo it's not implanting, we start doing testing, because we believe that embryo was very competent for the implantation. But we know that not all the 100% of euploid embryos in the lab they are able to implant, because perhaps they have problems in the metabolism, or any other system, that it's not only the genetics, that it's involved also in the failure.
All right. Again, thanks so much indeed for yet another question and answer. Okay, and there's another one, I think. And of course, there's a thank you from Marianne. And how big would the fibroids need to be for you to recommend removing them before frozen embryo transfer?
So that's a very good question. For the submucosal, so for type 0 or even 1, we always recommend to try to remove them no matter the size, because even they are very tiny, they are like in the line where we're going to put the embryo, and the implantation needs to happen. By contrast, for the intramural or subserosal, they need to be extremely large, and they will not be like causing really the failure. So it's more to do with, submucosal or intramural that are very close to the endometrium.
Okay, thank you for the explanation for this one as well. And Carrie has a different question. I've had 6 transfers, 5 failed implantation, 1 ending in a missed miscarriage at 8 weeks. Also had 2 natural pregnancies. One was chemical, another in miscarriage at 8 weeks. I'm on thyroid medication and tested positive for antiphospholipid PID syndrome. So been prescribed tinzaparin and aspirin for future pregnancies. I've had a biopsy on my uterine lining, and NK cells were borderline high, so they want to repeat the biopsy. 42. Is there anything else I should do or have tested? I've always had painful periods and worry this is an issue.
Yeah, so sorry, Carrie. So this is a, difficult case, but of course, I know you will be successful and you will get it. So, of course, antiphospholipid syndrome is also very, very problematic. So, in case you've been diagnosed for this and treat with so tinzaparin and aspirin in different rounds. Sometimes, if the antiphospholipid is the reason why of not implantation or miscarriage, we could eventually try to use other medication in parallel for the antiphospholipid syndrome. By contrast, of course, as long as you're 42, I will always recommend to work with euploid embryos if that's your eggs to maximize the implantation and then reduce the miscarriage.
Okay, thank you. Okay, and let's have a look at this question. So, what is your strategy for plasma treatment for endometrium? Patients on plasma quantity and how many settings and what kind of patients? Can you tell us?
Yeah, so we are doing this as a research investigation. So, in the event of this plasma, we normally, of course, do with own plasma from the patient, and then we have one treatment which is doing only once before the transfer on day 3, whereas others we have like from day 0 to day 5 multiple injections to maximize this. But it's more in the event of this investigator that depending on each patient will recommend what strategy to take.
Okay, I hope that was helpful for you as well, Kinza. So thank you. And Jane, when do you start? When do you start Clexane and prednisolone in a frozen embryo transfer? The reproductive immunologist has recommended to start both on CD6 in my frozen embryo transfer cycle. My clinic wants to leave it until after the transfer.
So prednisolone, we normally recommend to start minimum 10 days before the transfer, and the same for Clexane. But some immunologist doctors recommend to start prednisolone even with, the month before. But minimum, I would say, so 10 days before transfer.
Okay, thank you. And there's a thank you from a previous patient for you, Jane, as well, obviously. Okay, and there are more questions coming up. Let me see. Anna has a question here. I'm 42, had a fresh and frozen embryo transfer, very good quality, both failed, good endometrium, TSH 2.2, vitamin D sufficient, AMH very good for my age, and all other tests very good. Eat healthy, slightly overweight. Any suggestions in terms of tests?
So the main problem or the main argument for failure in this case, it's the age. So if it is own eggs, we really need to do PGTA to make sure that we only treat with embryos that are euploid. So that's the main thing. Of course, then receptivity in the event of failures with euploids and also coagulation and immunological disorders. But the first thing to do is PGTA.
All right. Again, thanks so much indeed, Anna, for the question. And let me go to Roxanne. I've had 2 failed embryo transfers, one frozen and one fresh, also one natural chemical pregnancy. I have very painful periods each transfer on due date of my period. I have had all the usual period pain in pelvis and back, exactly the same as on my period, despite the progesterone estrogen. Should I be tested for certain things before my next transfer?
Sure, I believe it's very important in this context of painful periods to exclude adenomyosis. This is really, really important. And again, as usual, to check if they are euploids or not embryos, and if also she has tested receptivity and microbiome and coagulations and immunological disorders. So if we transfer 2 embryos and there is not ongoing pregnancy, we recommend to do the whole testing before losing more embryos.
Okay, Roxanne, and thank you again. I think that again that was very useful for you. And let me have a look. Thank you so much for useful presentation. I am looking for a new clinic. Do you, in your clinic, offer all the studies that you mentioned in your presentation, including immunologists?
So that's a very good question. I don't recommend when it's, first patients for first IVF or first egg donation. But I explain, listen, regarding the evidence, our protocol, it's in case we have two euploid embryos that are not successful, then we will ask all this testing. By contrast, we have patients that say, listen, thank you very much for explaining this, but I want before the first treatment I will ever have to have testing for, immune system, coagulation system, 3D scan, whatever, everything. And then, of course, we do it.
Mhm. Okay, that again sounds great as well. And let's see. Jane has one more question here. What is the optimum level of ferrin? In your opinion, I am a vegan. I can get my lining to 8 millimeters maximum. My ferritin is about 30. I have started taking ferrous sulfate, 200 milligrams. I had to try and get it to 80, 90. Is this correct?
Thank you very much, Jane. So, depending on the laboratory levels, I cannot make sure right now exactly the level, but of course, you should try to maximize the normality of levels for ferritin. It's normal if you are vegan that this is happening to you, so I will recommend supplements, but also test other problems that could affect your implantation.
Mm-hmm. Okay. 30 is right at the lower end. Yeah, that was a follow-up. Sorry. Just additional one. So it's okay. Sorry, there is a short question. What is the name of the 3D scan you keep referring to?
Yeah, so it's a 3D scan. It's a scan that allows us to have the reconstruction of the shape of the uterus, to see if there is any septum, to see if there is any malformation, to see if there is adenomyosis. So very important problems due to the cavity, not the endometrium. So this is similar to MRI or even similar to hysteroscopy. But regarding the cost, normally this is less expensive. And if the expert doing the 3D scan, the sonographer, has a high skill, we have a lot of diagnostic with not even having an invasive procedure such as hysteroscopy.
Yeah. Okay. And this is the follow-up. Couldn't they see this on hysteroscopy and ECG? So,
Yeah, it's
uh,
different, but more or less the same approach.
mhm. Okay. I believe that now it's crystal clear, Kelly. Okay, and sorry, Jane has the previous patient, right? So just a follow up on the ferritin question. I'm worried in case by transferring SATs go up. Last year it was 60. Nobody knows why. This year it was 20. I don't want to do more harm than good.
Yeah, I believe this is not the big problem for implantation failure, the ferritin and all this system. Of course, ferritin, it could be, an indicator for other problems, especially when it's high, but not when it's low. So I would say it's not a big problem. So just follow the recommendation of the expert for nutritionists and try to use, supplements.
All right, and I believe that was really, really helpful. As you can see, thank you from Jane. I believe that that might be our final question from Anna. So if you have more, you know what to do. We still have a few minutes. So let's have a look. My last transfer was painful. So this is from the previous patient, right? Now considering going under anesthesia for the next one, would you recommend that?
So, of course, anesthesia is always very welcome, especially if patient is very stressed and having painful, but it's not really helping for the implantation rate because also if the woman is not awake, then we can have, more difficulties and we can even do more painful. So I only recommend for patients having, problems and do not tolerating at all the pain. Otherwise, what I recommend is a mock embryo transfer. Try to come relax, try to come and do exactly the transfer test to make sure how we need to enter in the cavity.
Okay, thank you for your advice for this. And there's a thank you from Anna. And I'm just waiting. So as you can see, someone is typing. So let's have a look if we have. Yes, there's one more question here. What supplements would you recommend to take?
Yeah, we always recommend to take folic acid, and then depending on the implantation failure problem, we could recommend vitamin D. We could recommend other folic acids such as the methyfolic, or we could recommend, iron or vitamin E. But it's more to do with our experts in the immune system unit.
Folate.
Yeah, of course, folate is always very welcome for everybody, but this is not, the possible problem for implantation failure, only in the event of the MTHFR problems. But of course, yes, we need to talk with the expert for the immune system and check what are all the levels, if vitamin D or whatever, or the supplement is welcome.
Okay. Thank you once again for the clarification. Again, someone is typing. Let's give it a minute. And let's see. Belinda has one more question. Just before transfer, do you recommend a lining check again? Because I have frozen embryo transfer on Monday, but the lining was last checked on Monday, just gone, and it was 11 millimeters.
It's a very good question, Belinda, but no, I don't recommend if the transfer was organized with a good scan lining and then with the control of progesterones. So it's more, necessary the control for progesterone levels than another ultrasound. Only in the event of bleeding, then yes, we need to repeat the scan.
Mm-hmm. Okay. Thank you, Linda, for the question. Anna would like to know, are 5AA euploid embryos better quality if they are from a 35-year-old than a 42-year-old?
It's a very good question, very difficult to answer. But of course, the evidence says that when euploid embryos, there are no difference between younger or elder women. So eventually, all embryos, euploids, could have problems in the metabolism, but this is not due to the age. So the probability for 35 years old or 42 years old 5AA euploid is exactly the same.
All right. Thank you for the clarification to this question. Definitely interesting. So thank you again. As you can see, there are some comments coming up. So I believe we will be finishing. And there's a thank you from Tony. Thank you for sharing. There's a thank you from Belinda as well. And there is another thank you. Brilliant session. Couldn't agree more. So thanks a lot, everyone, for joining. I do believe it was very, very useful for you and very interesting. And as always, very amazing. So many amazing questions from you. And I hope that was helpful. Dr. Laura, as always, brilliant to have you. Anything else you would like to add before we finish for tonight?
No, I just want to say that, of course, implantation failure occurs, but in hands of experts, doctors, the probability of not implanting is extremely low. Sometimes we have very problematic, malformations in the uterus or very, severe immunological conditions that are not leading to be successful. But generally speaking, if we do all this whole testing, if we transfer good embryos, and if we have the patience, we will be successful.
Perfect finish for tonight. So thanks a lot. And I just want to remind everyone that this has been recorded. You will have a chance to watch this, and the presentation will be, of course, available on our website, on YouTube channel. It will be available tomorrow, so you will be able to see it. Don't worry. And I just want to encourage everyone to register for our next event. It will be actually on Tuesday. Next Tuesday, we will talk about poor responders. So if you haven't signed up yet, go ahead and do it. And once again, I would like to thank and say that European Fertility Society is proudly supported by Phenomatch, as mentioned. So thanks for that. And of course, this is it for tonight. But of course, we will be back. I'm sure, Dr. Laura, that we will be able to have some more events pretty much soon. I'm already looking forward to it. It's always great to have you as our next expert. Now, enjoy your evening, everyone. And Dr. Laura, see you very soon. Take care and see you.
Thank you very much, Caroline. Good evening.
Bye.
Bye-bye.